What's up, everybody? It is the PA Professor. We're back with another video. Today we're going to cover SVT, or supraventricular tachycardia. So just like the word says, supra means above, ventricular, so above the ventricles. So it's a tachycardic arrhythmia originating above the ventricles. So my high-yield definition says just that. This is a tachycardia arrhythmia originating above the ventricle, and this causes rapid ventricular conduction through a circular accessory pathway from the atria, and I'll explain kind of what that means. But SVT, a lot of times when I saw it on Roche and some of my exams in school and the boards, they like to put this in young, healthy females for some reason. I think it is more common. I think the epidemiology does state that it is more common in young females. But I would just remember that little thing right there. So SVT, normally we have the atria conducting impulse. It goes down to the AV node hesitates, goes to the bundle of His, and boom, goes through, correct? What happens in SVT is right here, there's like, it's called re-entry, like a re-entry pathway. There's like a little pathway where the AV node, when it gets the impulse from the SA node, part of it goes down and conducts the ventricles, but there's like a circular pathway right here. And so it just keeps conducting, all the same while the SA node's still firing. What you get is this ventricular conduction haywire, because there's so many impulses coming through that AV node that the ventricles just go crazy. So that's kind of how I thought of SVT. Symptoms, obviously your heart's beating out of your chest, so you're going to feel like you have palpitations. This is the most common. Again, weird feeling in the chest. Syncope, pre-syncope, all these are common, but your most common symptom is palpitations. Here's your bread and butter for really any arrhythmia, especially SVT. So in an EKG and an SVT, you will see a narrow QRS complex tachycardia with no observable P waves. Let's look what that looks like. So as you can see here on this one-strip EKG, these QRS complexes are really, really small, less than one box, right? Look how skinny they are. And also, where's the P waves? These aren't P waves. This is right after the QRS, so this is your T wave. This is repolarization. Well, what's happening is there's no P waves because the ventricles are repolarizing while the atria is conducting. So really the P waves are hidden right here by these T waves. So you can't really see them. So that's what that means. No discrete, no observable P waves. And again, if you do kind of your 300 method to see how fast the rate is, this is regular too also, right? It can't be AFib. I know AFib has no P waves, right? But AFib's irregularly irregular, and this is regular, right? QRSs are regular intervals apart. But if you do your rate, right, because it's regular, you can go 300, 150. So this person's probably sitting in like the 170s, 180s. But this is what SVT looks like. It is a narrow QRS complex tachycardia with no observable P waves. Okay, so say you diagnose someone with SVT, right? How do you treat them? Well, are they stable or are they unstable? If they're stable, your first and best initial choice of treatment would be a vagal maneuver, because vagal maneuvers stimulate what? The vagus nerve, and the vagus nerve controls the heart rate and slows it down when you increase its tone. So you would try this. You would try slowing down the heart rate because it's a tachycardic arrhythmia. What are some vagal maneuvers you can try? Valsalva, like bearing down. You can do a carotid massage, and you can also do a cold water dive reflex. All of these stimulate that vagus nerve and help slow the heart rate down. Now, if these don't work, then you want to move on to medicine. And what's your medicine of choice? Adenosine. This medication kind of restarts the heart. It's got a half-life of, I think, 6 seconds. I may be wrong on that, maybe 6 to 8 seconds. So it's very fast acting. That's why when you see this in clinic, they will push it and then saline through the port, so they know they got all of it in there. And then I have ×2 right here, because I've had Roche questions ask me, you've done vagal maneuvers, you did 1 dose of adenosine, what's your next? But they've not converted, so what's your next best option? Do another dose of adenosine, 2 doses. But your medication of choice for SVT is adenosine. You need to know that. If they're unstable, right, they come in and they're in SVT and their BP's 80 over 50, then you want to get them out of that arrhythmia a little quicker, so you want to cardiovert them. Okay, so that was not a lot, but that's all you really need to know about SVT for PA school. So a high yield vignette question. A 26-year-old female presents to the emergency department with palpitations. Okay, this is right there. That first sentence screams, okay, it's an arrhythmia or anxiety. Her vitals are stable. Okay, that's important. The EKG is shown below. What is your best initial course of treatment? All right, let's go ahead and just broad overview of the whole EKG, right? It's regular, right? So it's not AFib. I don't see discrete P waves, but when you get to these precordial leads like V2, V3, V4, V5, this is like your typical SVT. You can see that you got narrow QRS complexes and then just a T wave. There's no P waves. And that's because these P waves are hidden under there. So if we go down to 2, which I like, again, the same thing. It looks pretty SVT to me. So we diagnose her with SVT, but it says, what is your best initial course of treatment? Well, is she stable? Is she unstable? She is stable. So in this case, your best initial course would be a vagal maneuver, such as Valsalva maneuver, carotid massage, cold water dive, reflex. So guys, that is it on SVT. Pretty quick, pretty straight to the point. You really just need to know kind of how to interpret it on EKG, recognize it on EKG, and treat it. Thank you guys for watching so much. If you can already subscribe, like the video. Good luck on all your boards, all your exams. You're going to do great, and we'll see you in the next video.